About 24 when she came to see me with the chief concern of protrusion and lip incumbency. And this is her panorex. Molar is class 1 on the right hand side but class 2 on left hand side.
Rồi xoắn lại.
Xoắn cái gì thế? Xong rồi đọc khoảng 6 lần.
Thế rồi thấy sao?
The diagnosis for this patient is she is class 2 high mandibular angle by massive protrusion with gummy smile. So treatment plan for this patient is because she has endodontically treated upper second premolar. So even she is very protruded, I still decided to extract upper second bicuspid and 2 lower first molar to recheck upper and lower incisors. And I would like to use mini screws on upper arch to intrude and recheck as much as possible. So here you can see the different approach with this kind of case because she has no crowding but she's very protruded. So for this kind of case, I would like to bond everything from day 1, but I will extract after I align and label all the teeth. Then I will start retraction right after extraction. So here you can see I put mini screw, mesial to upper first molar.
Thay luôn SS lên vậy.
On both sides.
Bà đi 013 một tháng.
Nhìn cái dây SS nó vẫn còn.
And I start to recheck.
Không sự thật.
If I would do this case again, I will place the mini screw mesial to upper second molar. The reason I choose to place mini screw mesial to upper first molar is because I think it's the safest place to place the mini screw. It won't interfere the root. But the problem is if you insert a mini screw in a recent extraction socket, it's very easily that you insert your mini screw into the socket. So once you recheck, the root of premolar will be very close to the mini screw. So the screw will loosen during treatment. So here is I use posterior turbo to unlock the bite because sometimes if the buccal segment interdigitation is very good, especially for bimetric protrusion without crowding. Usually, sometimes it's really hard for you to recheck because of the very solid occlusion. So sometimes you need to use posterior biturbo to unlock the occlusion. Then you can slide very fast.
Nhưng mà nhìn cái chuông nó biến dạng
so here you can see on the top is 6 weeks after I put posterior turbo. I am able to close the space for about 2 mm. You can see the distal end of the wire. Then I place 2 mini screws between upper central incisor and lateral incisor to help me to intrude upper incisors. This is the unposed smile for the patient. You can see she's really gummy. So the mechanics here will be, I use 2 mini screws for retraction and another mini screw, 2 mini screws for intrusion. So if you place the mini screw mesial to upper first molar and you start to recheck, here is the central resistance of upper arch. So when you recheck, you will see clockwise rotation of maxilla. So usually you will see the heavier force you use, the heavier, the stiffer wire you use, you are going to have severe open bite posteriorly. So if you use mini screw to recheck, either in extraction case or whole arch distalization case, and you see posterior open bite, which means the force level is too high. You need to reduce the force level. And another thing is, maybe like this case, I place the mini screw really high, it's far away from the wire plane, so you are going to increase the moment. So if you remember my class 2 open by case, I place the mini screw really low, it's very close to the fuso plane. You won't have this kind of posterior open by during retraction.
Vậy bà sẽ dùng dây thép cứng để đánh là cả khối luôn.
So if you want to correct this kind of complication,
lên kết khối chỉ cần dùng
for
cái
like this
1925S
case,
thì đấy.
you put mini screw to do whole arch retraction and intrusion.
Vậy cả đám đều lên hết.
And you can also use these 2 mini screws if you don't think you have enough overjet. You can also use these 2 mini screws with class 3 elastics to recheck lower arch to create overjet, so you can recheck upper arch more. But you need to be very careful if you want to use class 3 elastic from lower to upper mini screw. Make sure you are using soft arch wire, like 14 by 25 copper 9 tie or 18 by 25 copper 9 tie. Because if you are using stainless steel arch wire, then you use wire elastic from lower arch wire to upper screw. All the force will go to PM joint. Sometimes patient will have joint pain. And the key to correct upper arch anterior dumping is make sure your intrusion force is lighter than your retraction force. Otherwise, you are going to have proclination of upper incisors. And this is how I hook the power chain to the wire to mini screw. You don't need to use an extra crimpable hook. Just directly hook the power chain on the wire. So why 2 mini screws? The sequela of using just 1 mini screw in the middle would be sometimes you have soft tissue irritation. And the second thing is if you didn't control the force good enough, sometimes you will ruin the smile arc. You are going to create a smile arc like this. I remember when Dr. Burstone came to Taiwan to speak, he said that smile arc doesn't exist. Smile arc is just a fallacy. Is it true? Here is a very interesting diagram from Dr. Ramsey. If you look at the balloon, on the left-hand side, the balloon has flat smile arc. On the right-hand side, the balloon has very good smile arc. Dr. Burstone said that if you want to enhance the smile arc, ask all of your patients to smile like this. Take initial photo. That they all have very flat smile arc. Then after treatment, ask all of your patients to smile like this. Then usually they have very good smile arc. But if you look at the balloon on the top, you can see even the head is tilted. The smile arc is still over there. Even the head is tilted on the other way, the smile arc is still over there. So it's not just because the head position could be changed. It means the smile arc doesn't exist. I think the smile arc really exists. So now sometimes because I feel like if you put 2 mini screws between central and lateral incisor, it's very easy to loosen the mini screw to be loosened. So sometimes I change to only 1 mini screw between central incisor, but you need to be very careful to use very, very light force, less than 20 grams.
20?
So here is our case again. We use mini screw to intrude and recheck. And if you compare from 16 months to 19 months,
buộc xong đó thừa cắt đi.
the wire position to to the minuscule, you can see the amount of intrusion.
Nó có hai loại đấy.
So again, you need to keep the intrusion force lighter than the retraction force to prevent anterior teeth flaring. And this is how patients smile. Still gummy. And if you compare the set, you can see the amount of intrusion. Now after 25 months, you can see I removed the minuscule because I feel like the space closure is slowing down. So I removed the minuscule and I changed it to 018 Australian wire. And this is patient after 25 months treatment. If you went to pre-congress yesterday, here is the panorama of two different kinds of patients. On the left-hand side, you can see it's a panorama from a very brachyfacial patient. Usually, a brachyfacial patient, they have very strong masseters. They have strong occlusal force, so you can see the size of the sinus is very small. And when you screw in, you will feel the resistance of the bone because they have higher bone density compared to the dolichofacial patient. So if you see a patient with a very big sinus, always make a backup plan. If you want to propose non-extraction treatment plan with minuscule to the patient, with this kind of very big sinus and very thin bone, sometimes the screw loosen all the time, and it's really hard for you to use the screw. Maybe you need to change to extraction plan. So always inform your patient before you position the minuscule. There might be a chance that the screw will be loosened, and we need to rescrew it. Otherwise, we cannot proceed our treatment. And this is how I finish the patient in 30 months. This is how the patient smiles. The comparison of initial and finish buccal view. You can see, especially in my extraction case, I always like to widen the arch because for now, the relationship between extraction and obstructive sleep apnea is a very big issue. So especially for my extraction case, I always like to widen the arch to ensure that patient's tongue have enough space to position. So you can see, even I extract, I still widen the arch. And this is the panorama before and after treatment. And you can see the change of the gummy smile. And in this patient, I also do some smile chaining. And here is the change of rest position. Now patient can close her mouth very naturally. And here is the lateral view. Comparison of set. So what we have achieved in this patient is we have bodily retraction and intrusion of upper incisors and upper molars. And for lower arch, we actually project the molar a little bit, but we still retract lower incisors a lot. And in this patient, I also use A6 retainer on both arches to retain her. And this is how patient looks like 12 months after treatment. Intraoral picture.